Welcome to Journal Club, brought to you by the American Association of Sleep Technologists. Today we'll be speaking with an author of an article entitled, "Are We Ready to Define Central Hypopneas?" Commentary on Randerath et al., evaluation of a non-invasive algorithm for differentiation of obstructive and central hypopneas. The editorial is by Dr. Conrad Iber. It's in the journal Sleep. The article is by Randerath and colleagues, also appearing in Sleep. Disclosures: Dr. Iber has indicated no financial conflicts of interest. For the main article, it was not an industry-supported study. Dr. Randerath has received support for speaking and/or research from Weinman, Philips Respironics, ResMed, Heinen, and Lowenstein. The other authors have indicated no financial conflicts of interest. Our speaker today is Dr. Conrad Iber, Professor of Medicine at the University of Minnesota Medical Center and Medical Director of the Fairview Health Services Sleep Program.
Sure. So I'm actually in the pulmonary and critical care division there as director of their sleep section. Okay. And I'm a professor of medicine in the Department of Medicine. And then I'm also the medical director for the sleep program, which is a partnership between the university and Fairview Health Systems.
Okay. You're also the chair of the ASM scoring manual, version 1.
Okay.
So you were chair of that committee and produced that volume, and so have some expertise with regard to scoring of central sleep apnea, which is what we'll be discussing today. So before we get to the scoring, can you just give me an idea of what your perspective is on how central apneas are generated, why they happen?
So there's a pacemaker in on the floor of the brainstem, and that pacemaker has regular rhythmic activity for inspiration and for exhalation. And that pacemaker activity determines the rhythm of breathing and the timing, the depth. There's a lot of information that comes to that pacemaker to help integrate the pattern of breathing. But it's an interruption in that pacemaker activity that causes central apnea, essentially a cessation of pacemaker activity. And there are a lot of ways in which that can happen, and so that's a real important concept, that actually there are multiple ways in which one can have a central apnea, and some of them are more serious than others. So what we observe in terms of a central apnea is further out than the brainstem, obviously. What we observe is an interruption of rhythmic breathing activity, and that's one of the problems. It's our ability to detect that with our sensors that's really important here. So we can detect, we can't detect the pacemaker activity, so we can detect breathing itself, but of course if there's obstruction of the airway, well then that's a false signal. So we have to detect breathing effort. And even breathing effort can be problematic if our sensors aren't really detecting the output. So the closer we get to, the actual neural activity, the better. It would be nice to look at neural activity. That's not very practical. We can look at EMG activity of the breathing muscles. That's very good, but sometimes difficult technically to get because of obesity and because they're surface electrodes. So we're often looking at movement, and movement is further down the line. We have to be sure that we're detecting respiratory effort in terms of movement. And of course, with obstruction, when there's no airflow, it reduces the amount of movement that can occur, and so that dampens the amount of movement. So I don't know if I'm supplying you with the answer you wanted, but I wanted to kind of first look at the anatomy of the rhythm of breathing first, because that it does determine how we detect what a central apnea is. But the simple answer is central apnea means there's a cessation in the rhythmic activity of breathing, and it's our ability to detect that and define that, which makes it kind of a technical challenge.
When you say that central apneas are a function of the central pacemaker, does that mean it's always one area of the brain that's affected when central apnea occurs?
Well, yes. In the that's where the rhythmic activity of breathing comes from. But remember, it doesn't require a structural change. In fact, I think we'll all recognize what are called transitional apneas, where somebody takes a deep breath, and there are two things that shut off pacemaker activity. One is just the inflation of the lung, which will shut down the pacemaker activity.
So that's the mechanoreceptor feedback.
That's right. And then the other is lowering of CO2 by just a few millimeters can shut off pacemaker activity. And so that's very commonly observed. In fact, if you go back in the literature on central apneas and you look carefully, you can find evidence for central apneas. Probably nearly half of people will have evidence of central apneas during polysomnography. It's just a matter of the frequency and what they reflect. A central apnea due to a brainstem tumor is much more frightening, obviously, than a central apnea that's due to a deep breath from an arousal.
So we're talking about the medulla here, right? Is where the pacemaker cells are. So structural damage, changes in blood gas composition can affect this. But then something that I think is becoming more and more recognized is effects of opiates on the breathing pattern that can cause central apnea as well. Is that your understanding?
Yeah, and I although we don't understand that area very well, the pattern is obviously quite different. And these patterns are quite different between heart failure and opiates and sleep disruption with arousals. They look different. And somebody mentions the human brain's ability to detect. It's actually pretty good. The ability of the human brain to detect patterns is actually relatively good. And so there are some differences in patterns between these, and one can develop around that some rules, and some rules have been developed, and probably others need to be developed. And but you're right, that's probably a disease of the pacemaker itself, because one notes in narcotic-induced central apneas that they're very irregular, whereas most of the other causes for apnea have a precipitating cause like an arousal, or they're due to delayed circulation time, in which case you have incredible rhythmicity to it, very good periodicity. And so periodicity suggests a sort of an underlying physiologic cause, whereas irregularity of breathing pattern, like we see in medullary breathing patterns or in breathing patterns due to opiates, are irregular and suggest a more concerning etiology.
And then you've sort of been touching on the periodic kinds of breathing, with heart failure, with the Cheyne-Stokes breathing pattern. Also with altitude, you can get that periodic breathing pattern as well. And is your understanding that the mechanisms in the brain are intact and they're responding to the stimuli in a different way in those conditions?
Yeah, as a matter of fact, ventilatory drive in most of these conditions, but not all of them, is high. In fact, these people are not in danger of stopping breathing and dying, like they might be, in situations where there's a disease of the central pacemaker. Ventilatory drive is high, and in fact, the reason that it occurs, it's so high that the CO2 apnea threshold is being touched on each time. And so the problems really are it causes sleep disruption, periodic desaturation, and some of the consequences, even cardiovascular consequences, excess sympathetic activity. So there are consequences of those patterns that identify bad outcomes. In fact, Cheyne-Stokes, in the setting of heart failure, has for quite a long time been recognized as sort of an independent predictor of higher mortality rate. And so it's a bad marker for how bad the problem is, but in and of itself, it's not a risk for cessation of breathing and respiratory arrest, per se, if you understand, because these people are actually in high ventilatory drive state.
Which is the loop gain concept?
Yeah, and pretty complicated concept, but
right.
Essentially some of the underpinnings are the higher the ventilatory drive, like hypoxia, the more likely this is to occur. The closer that somebody is to the threshold, the more likely that periodicity will cause apneas to occur, and then the larger the lung volume, the more dampening there is of the respiratory system. They're called plant gain. So there are lots of different components of this, but those are sort of the basic principles.
Okay. I want to go back to something you said at the beginning about the obstructive versus central, and in your editorial you do say that there's may be an obstructive component to a lot of central apneas. And our measurement of this is indirect and maybe inaccurate. So what's your sense of how much there is really pure central apnea? And in how many cases does the presence of a central apnea actually result in some partial or complete closure of the upper airway? So are we dealing with, how often are we dealing with pure central apnea?
Well, like any good politician, I'll dodge that question and sort of answer it indirectly. So if you induce periodic breathing by hypoxia in a person who has no obstructive sleep apnea, a subset of people will develop obstructive sleep apnea. If in patients who have heart failure, severe heart failure, and have Cheyne-Stokes breathing and develop secondary obstructive sleep apnea, a heart transplant has been reported to reverse the obstructive sleep apnea. Conversely, if you take obstructive sleep apnea patients and give them carbon dioxide, like Jerry Dempsey has, in a subset you can eliminate obstructive sleep apnea. So as confusing as all that sounds is I'm linking the two. Once you've set up periodicity, you can get secondary obstruction in some susceptible people. If you have obstructive sleep apnea, if you develop Cheyne-Stokes breathing pattern, you can develop obstructive sleep apnea in some patients with heart failure. So when we say they coexist, they truly coexist, but there might be a driving force. If the primary problem is heart failure and the dominant feature of what you're finding is a periodic breathing pattern with a long circulation time and very minor obstructions at the beginning of each breath, I guess my clinical experience with this population has shown me that they require very little positive airway pressure to unobstruct the airway, but they require a lot of work to try to correct the Cheyne-Stokes. And so it seems like the primary problem there is Cheyne-Stokes, and that the secondary obstructive apnea is not really the problem. On the other hand, in the patient without heart failure who has very severe obstructive sleep apnea and develops mixed apneas, the central components often go away when you treat the obstructive sleep apnea. So part of this is looking at the technology of what's being recorded, and part of it is recognizes the milieu of what is the patient's condition. Is the primary condition really obstructive sleep apnea, or is it Cheyne-Stokes breathing? And what's the dominant feature of what you see on the polysomnography? Is it really dominantly heart failure or dominantly obstructive problem? So I know I've dodged a bit here, but I think in simple terms, when you have a patient with heart failure who has components of obstruction and Cheyne-Stokes, you're often treating both.
Which segues nicely into my next question. The first scoring manual kept the scoring of mixed apneas. Mm-hmm. And the revision is actually keeping the scoring of mixed apnea as well. But I know there's been a lot of discussion about whether that's a valid category for apnea. It does involve now that the first portion of the event has to be central and the second portion has to be obstructive, but it doesn't give you any idea of what percentage of one or the other is required in order to make a mixed apnea. And where do you stand on that controversy?
Uneasily, I guess. I think that one can have within a given patient some breaths that are dominantly central with a mixed apnea and dominantly obstructive. So to try to make a clinical diagnosis of what the patient has based on how much time is spent in the central and obstructive components to me seems a little artificial. So I think the fact that patients develop when you apply CPAP, and again, this is clinical experience, and I have to acknowledge that there's not a lot of data here, but the patients who develop central apneas and often develop mixed apneas, and the patients who have mixed apneas to begin with often develop central apneas when you apply CPAP. So the so-called complex sleep apnea or CPAP emergent sleep apnea, central apneas are a common feature, either as part of the mixed apnea or as independent events. And so mixed apnea tells me that a patient is susceptible to central apneas. That's what it tells me. And I wouldn't think it would be very useful to assign any amount, specific, kind of threshold amount of time or a percentage of the apnea. It does make some sense to me that the duration of the central event be something comparable to at least 2 breaths. That meets some reasonable sense to me. Otherwise it just could be a normal expiratory duration. So I think beyond, the duration of 2 breaths, I don't know that anything beyond that makes any sense to me. And for the future, I think that might be a reasonable way to define a mixed apnea, which would be that if there is an apparent central component, that it occupies at least the equivalent of 2 normal breaths duration.
Okay. Knowing, of course, that in common practice, the mixed apneas are thrown in with the obstructives in order to reach criteria for a diagnosis of OSA and to pay for CPAP.
Yep.
But there isn't the equivalent on the other side, that you can't take half the mixed apneas and put them in for central apnea if, for example, you're trying to justify the use of ASV or some more complicated treatment for central sleep apnea.
Yeah, nor can you use central hypopneas yet for that purpose, is my understanding.
Well, it depends on the insurer, is my understanding. Some will accept it, and some won't.
All right.
And we'll get to that. Well, in fact, why don't we discuss that now? Some people have proposed a 50-50 rule that if there is coexisting central and obstructive apnea, that at least half the index has to be comprised of central apnea. Others won't diagnose central apnea unless the obstructive index is less than 15 or less than 5. And all of this, I think, aiming toward justifying complicated platforms for PAP therapy. And where do you stand on that in terms of making a diagnosis of central sleep apnea in a patient that may have some obstructive components?
Yeah. Again, I guess it's going to have to be arbitrary and based on consensus, because we don't have a lot of data, and also maybe based on common sense. It makes sense to me that a patient have a certain dose of obstructive sleep apnea before you use CPAP. And I think it's a little harder with central apnea because of the plasticity, which everybody recognizes. In particular, in unstable heart failure, the percentage of breaths that are obstructive and central can vary on a night-to-night basis quite substantially. And so if you do a single-night study and you're basing your decision on that, it's a little artificial. So I don't know that I have, from any empiric evidence, the data on what proves that patients need ASV. That's really the question here, I think.
Right.
The additional costs and complexity involved.
Maybe we'll hold off on the treatment part of this until a little bit later. But I do want to get to that as part of this. So I want to go back to how central apneas are generated, and I think what you've been talking about so far is pretty much about non-REM sleep. And can you talk about what happens during REM sleep and how those periodic breathing patterns seem to go away, and what else happens to breathing with reference to central apnea during REM sleep?
Well, first I might just comment that periodic breathing in central apneas actually are more common in non-REM, but they're specifically more common in N1 and N2 than in N3. So the deeper the sleep, and I think that might provide us some understanding of why we see them less in REM. But in N3, the carbon dioxide level often a little bit higher might be part of the reason. But it's striking in some patients how Cheyne-Stokes breathing and central apneas tend to disappear in N3. And it's quite variable. And certainly in REM. Now, this is overstated. That is, it's often said that you don't see Cheyne-Stokes breathing in REM, and I certainly have seen exceptions to that. It's just not as likely to occur. And probably a couple of reasons for that. And one, again, may have to do with changes in ventilatory drive. And then the other reason is, maybe a hypothesis, that it has something to do with desynchronization. Synchronization tends to support periodic phenomena like seizures, as an example, in the EEG. It's part of the brain. And so there's just, to the extent that it participates in this process, if it does, it might be another reason why periodic patterns are not as well supported in REM. So those are maybe a couple of explanations for why we see less of it, but again, I think it's overstated to say it doesn't occur. It can occur. The other thing that's really important to remember, and it's not a very high volume of central apneas, but occasionally patients are described as having obstructive sleep apnea only in REM, but if you look carefully at what's happening is they're having occasional events, but there's no snoring and there's no flattening, and it looks like effort is falling. And that's actually what is happening. And these are central hypopneas that are often associated with clusters periodic of eye movements. And those are due to inhibition of the respiratory muscles. And those are central events. Again, there aren't usually a lot of them, but they can create confusion. And sometimes patients will have CPAP titrations during those events as a result of observation of desaturation and hypopneas. And that actually is a misdirection often in that setting because the patient's not having an obstruction in the airway. Generally, this tends to be more of a problem when they also desaturate because it catches everybody's attention that there are desaturations occurring. And so in obese people in particular who tend to desaturate with these minor hypopneas or people with low saturations to start with due to lung disease will show these, and this perhaps 20% of adults will have this, that is prominent hypopneas during rapid eye movement activity. And so that can create some misdirections in definitions of what the hypopnea is. And this is one of the reasons I'm concerned about Randerath's definition, that has not been considered as a possibility here. And also with how we manage it. Applying positive airway pressure, it may not make sense under those circumstances.
But you were talking about central apneas as being part of the pacing system before.
No, I'm talking about hypopneas now. Sorry.
Okay.
Actually, I was talking more about hypopneas where there's inhibition of effort.
So this is neuromuscular rather than medullary pacing.
Well, that's right. It's inhibition of the respiratory muscles during basic activity. Can be quite dramatic. In fact, if you're recording EMG activity of the diaphragm in animals, there'll actually be fractionation and loss of EMG activity transiently during these period of rapid eye movements.
Mm-hmm.
So,
a different mechanism completely.
Different mechanism. But going back to the question of apneas, central apneas that occur, they are certainly less frequent in REM. Mm-hmm. Periodic breathing is generally less frequent, and central apnea is less likely to occur. Certainly can occur, and even frank Cheyne-Stokes can occur, but it's less dense and less likely to occur.
Okay. Well, let's go back to that measurement. And this, I think, measuring the muscles of breathing, measuring the pacing somehow, and we're relying on these very indirect measures. Do you think there's a better way to determine whether an apnea is central than what we have in the usual sleep study?
Yeah, I struggle with this. I don't know that I have a good answer to that. I know that when I have focused in thinner individuals on carefully placing diaphragm EMG, I found it useful, but oftentimes that's a challenge in obese people. And it's not been very practical. I use, when I've done research studies and placed catheters in the nose to measure upper airway resistance or esophageal balloons, it's an uncomfortable thing for many people, and a kind of routine use is not very practical. So I don't have an easy answer to your question there. I would say what you should do, and some of the common mistakes are to say, goodness, there's no effort here, and if you turn the sensitivity up on the abdominal tracing, you'll find that in fact there are efforts present. And so just making sure that you're making adequate use of the devices that you have, and you're trying to keep the big breaths within range of the displacement of the channel, then really don't worry about that in this case. You might need to temporarily turn up sensitivity and identify whether efforts are present or not. And if they are, then it's not a central event.
Right. With the exception of the hypopneas, and let's try and move into focus on those if we can. That effort obviously continues with a hypopnea because there's continued airflow. Right. And one of the concepts that I think I've heard tossed around is this idea of the effort remains proportional to the amount of flow. And if the effort becomes greater than the flow, then there's more of an indication that something's obstructive. So when you distinguish a central apnea, what are you looking for in a central hypopnea? Sorry, what are you looking for in the recording?
Well, actually, sort of starting from the opposite view, which is how much of this has been written, is there an absence of obstruction? So,
which is kind of the way the scoring manual second edition is addressing this. Yeah.
And I think that's a reasonable first step, which is to say, goodness, if you're hearing snoring and you're seeing flattening, then be very careful about thinking about calling this a central event. So it's almost sort of exclusionary.
And here are the rules for scoring central hypopneas from the article by Barry and colleagues in the Journal of Clinical Sleep Medicine that accompanied the new version of the scoring manual. And the rule is that if electing to score central hypopneas, score a hypopnea as central if none of the following criteria are met. 1. Snoring during the event. 2. Increased inspiratory flattening of the nasal pressure or PAP device flow signal compared to baseline breathing. Or 3. Associated thoraco-abdominal paradox occurs during the event, but not during the pre-event breathing. Here are a couple of recordings of airflow and esophageal pressure. In the bottom tracing, the airflow becomes flattened during the period of decreased flow, and this is accompanied by a progressive increase of esophageal pressure, and this is used to define an obstructive hypopnea. In the central hypopnea, in contrast, there is no flattening of the nasal pressure signal, but there is continued esophageal pressure fluctuation, although there is no crescendo change in esophageal pressure. Here's an example of obstructive hypopnea with snoring channel, nasal pressure, thermal signal, chest and abdomen, and oxygen desaturation. Note that during the hypopnea there is flattening of the nasal pressure signal and only a slight decrease of the oral nasal thermal signal, and it's accompanied by very loud snoring. So these features lead to the diagnosis of obstructive hypopnea. In addition, at the bottom here, we note that there is thoraco-abdominal paradoxing, that is, the chest and abdominal movements become out of phase, but then this reverses at the end of the event, and the movements are then in phase for the remainder of the recording. In contrast, here's a hypopnea that occurs in a patient having periods of Cheyne-Stokes respiration. We see the nasal pressure signal does not flatten. It decreases in amplitude but continues. And we see other measures of flow, including the RIP flow channel, are also similarly not flattened. Respiratory effort decreases during the event and then resolves at the end of the event with no evidence of thoraco-abdominal paradoxing.
Perhaps a little more difficult is to use the analysis which you've been talking about, which Randerath did, of course, with esophageal manometry, but it's hard to do in practical terms, which is to look at the sort of proportionality between flow and effort. And, of course, you can't use the thermal sensor because that's non-quantitative. So if you're using the nasal pressure, one of the problems with that device is that because it has alinearities at low flow ranges, it tends to disappear. And so it will look like absence of flow. And so once you're getting down to lower flows, it's very problematic sometimes to determine. And I guess I would say the absence of nasal pressure and decreased airflow and without any evidence of airflow obstruction is suggestive of central apnea. But I think, both this article by Randerath and what literature is presented in the field suggests that this is really a tough area, and I don't know how much precision we can get to, and maybe we have to acknowledge, there are some times, much like I think we all recognize there are times when we can't score the EEG. When patients have, underlying encephalopathy or structural brain disease, and really it's not possible to adequately score the sleep stages. There may be some events that are simply ambiguous, and we seem to be, one of our fears, I think, in this field is we're afraid to use that word. We're afraid to say, this is more clearly, these are clearly central events. These are central apneas. These are obstructive apneas. These are clearly obstructive apneas. These are suggestive of central events, and some of these over here, I'm not so sure.
Yeah, I get that a lot in the interscore reliability program, where people say, "Just tell me what the right answer is. Don't give me any ambiguities."
So there are some ambiguities, and central hypopneas would be one of those. And I think we all recognize that sometimes that's due to loss of a sensor. Well, once you have poor quality, and especially, if you've lost a nasal pressure signal and you can no longer look for flattening, or your snoring signal is gone, and so you're looking for signs of obstruction and you can't use that anymore, well, then you're in sort of uncharted territory.
Right.
Having said all of that, we have to do something. And I think these rules help us. I think if we acknowledge the lack of precision for central hypopnea definition and say, okay, this is the best we can be at this point, and then look at the patient,
yeah,
and say, okay, in what context is this occurring? Are these central hypopneas occurring where there are also central apneas? Well, yes, they are. Well, then they may well be central. Okay.
Mm-hmm.
Is this occurring primarily in a patient who has obstructive sleep apnea? Well, let's be careful about calling these obstruction. And I know that isn't very satisfying, because you would like to be definitive based on calling a specific problem. But you also have to interpret the sleep study. And I think that's where, the interpretation process at the end has to take into consideration what the data has presented and what the patient has, what the conditions are, and make a best call based on that.
Mm-hmm.
So,
one more technology thing. I went to a lecture by David White at one point where he talked about this delivering a pulse of positive air pressure to determine if the airway is open or closed. Do you think that's a valid methodology?
I think it's an exciting opportunity to establish validity for it. Yeah, it's in the sense that it makes good sense. We used to use the opposite, right? We used to look at the airflow signal, and if we saw cardiac oscillation, we said, well, the airway's open. That's why this technique was developed. And so, yes, if you can deliver a pulse and you demonstrate a large reservoir on the other side of this, which is what this dampening effect shows,
right,
it makes good sense. It would be nice to have some validation for that, but it certainly makes logical sense that would be a good method.
Mm-hmm. Well, then moving into the treatment part of this, the practice parameter for the Academy says that CPAP is a recommended treatment for central apnea as well as obstructive apnea. So is all of our discussion about trying to discriminate between these two kinds of events kind of moot when it comes to the end, that these people go on CPAP anyway, and then you find out what's left after you've put them on CPAP?
No, I think there's a lot of utility in distinguishing between these. But I would say, it may not be based on just the central hypopnea rule, but rather on, the entire interpretation of the study. If patients have, something that's not very common, which is a central apnea syndrome, they'll have central hypopneas as well. And they can have a lot of sleep disruption. And in fact, the use of CPAP or autotitration in that setting is probably not very effective for treating central apnea in that setting. Now, in some respects it might be. It increases, size of the lung volume, and so it might dampen these. It might have an effect. But, there are sometimes other simpler methods. Using oxygen alone is also sort of expensive, often not covered, so it may have an effect on these patients. If it's driven by arousals, if these are central apneas driven by sleep disruption, and I've seen central apneas that were caused by periodic limb movements. I had a patient who had a dermatitis with lots of arousals and had transitional. If these are transitional events and it's dominantly driven by arousals, then simply consolidating sleep is...
With a hypnotic.
Can be effective. So I think there's some also let's move from there. Central apnea is something much more common, which is Cheyne-Stokes breathing. Heart failure, very common problem. Well, obviously, that now you're identifying somebody who has a higher mortality rate. That's actually something important to know about. And if you apply CPAP to a volume-depleted patient who has heart failure, you actually are decreasing cardiac output. And there may be some, based on the CANPAP data, that actually may be adverse. So you wouldn't want to apply CPAP under those circumstances. It may actually be adverse. If you apply CPAP or ASV to somebody who's having central events on CPAP, you may worsen, I'm sorry, not ASV, but if you apply spontaneous mode bilevel or CPAP to somebody who has emergent central apneas, you may worsen the problem. So identifying that they're having that mixture of apneas, hypopneas, and mixed apneas, if that's what's evolving as you're applying what you're doing, be careful. You're likely to make it worse. So yeah, it's important to know what the patient has, and it's important to not apply a therapy which may be adverse. And I think the idea that CPAP can be used in obstructive apnea, and when you are looking at the tracing and it looks like central apnea or central hypopneas, is also true, which is there are some patients in whom our sensors are not, the gain is not properly set up. Maybe the breaths are only a breath or two of obstruction, and so you aren't recognizing that there is in fact sort of underlying obstructive apnea. You apply CPAP, and the small amount of obstruction goes away, as does the whole periodicity of the breathing pattern. Well, those people probably have what's called ventilatory overshoot. And what they're doing is they recognize an obstructive event neurologically, and they have an incredible ventilatory response. And once they do that, they develop central apnea afterwards. Something, I published back a few decades ago.
I'll have to look that up for our reading list.
Look, mixed apnea. And it was due to ventilatory overshoot. Mm-hmm. Very nice, actually, tracing of it. And an obstructive apnea patient can develop ventilatory overshoot. And if they have tremendous ventilatory overshoot, most of what you'll look at is a central event. This is why I'm very careful not to apportion the size of the event as the cause of the mechanism. So these are patients who develop very long central events due to obstructive sleep apnea, and they had tracheostomies. And once I unplugged the tracheostomy, everything went away. So similarly, once you apply CPAP to somebody like that who has a lot of ventilatory overshoot, then the central events will disappear. So.
Okay, last question.
Yep.
Sleep medicine seems to be moving in the direction of out-of-center testing for a lot of patients.
Yep.
And I think from the academy perspective, the big issue is proper screening of patients and identifying patients who are at high pretest probability of obstructive apnea.
Yep.
And part of that is to exclude patients who might have reason to have central sleep apnea, with the assumption that out-of-center testing can't accurately identify central apneas, which is based really, if you read the paper carefully, on the lack of evidence that it is accurate in diagnosing, in identifying and scoring central sleep apnea. Do you think that's valid, that we should say anyone with heart failure should not have an out-of-center testing because we can't distinguish Cheyne-Stokes breathing on a home sleep study? I mean, we look at the entire EEG and the staging and everything when we're scoring this, but really with the scoring criteria for central apnea are the same as obstructive apnea. They're based on the same signals. If we are recording the same signals in an out-of-center test, why isn't that just as valid for diagnosis?
Well, that's a good question. I guess there are several layers to that. And I might just take sort of the high altitude, which is we should be applying tests that have less precision to the patients who are not likely to be hurt. So if any test is not quite as good, maybe you want to reserve that for people who are less likely to be hurt by a mistake. So just to a word of caution. And I think that the Academy rightfully took a position of adopting, the standards for out-of-center testing, which eliminated people with a lot of comorbidity and chose people with high pretest probability. Why? Because there's some concern, maybe yet to be set aside, that home testing is not quite as good as laboratory testing, not quite as good. And so that's kind of the high-altitude view. If we drill down into this, I think your point's well taken. I mean, we measure the same things. We have the same sampling rates, essentially short of the EEG. Everything's there. And so one should be able to make a call as to whether this is Cheyne-Stokes breathing or obstructive sleep apnea, for instance. And but I might, it sort of begs the question, well then, if you know the patient has heart failure, and you know that heart failure varies quite a bit on a night-to-night basis, are you going to be comfortable with one study with out-of-center testing in which you really can't apply any therapy for using an auto-titration device then to move forward to treat the patient? Knowing that auto-titration devices might actually exacerbate the problem if they're, auto-titration CPAP devices in the setting of Cheyne-Stokes. Is that the right approach? Or would it be better to bring the patient in and be able to offer, adaptive cerebral ventilation if you felt it was appropriate, if you felt, and there's some controversy about that, of course, in this setting. So I guess I have, for the time being, until we get a little bit more safety data on doing this kind of study in heart failure patients, I think we should stand back from that. But I recognize that, and I guess the other, maybe one third reason, I think as we should push out home studies into the field to some extent, right? So we don't have a extremely skilled polysomnographer necessarily looking at every one of these, somebody who's used to looking at Cheyne-Stokes breathing and knowing the difference. I think we then run the risk of having things misidentified because not everybody can be an expert on this. And I certainly have had the experience myself with what I thought was a skilled polysomnographer coming in the morning and saying, the patient has obstructive sleep apnea. I've tried CPAP. It's not getting any better. Got worse. And I look and it's classic Cheyne-Stokes breathing, and I realize that I have some teaching to do. And so I'm a little cautious about pushing it out to lower levels of expertise, and maybe that's takes time. Maybe at some point with better instrumentation, automatic reading. If we characterize Cheyne-Stokes in better ways, like you have to have 5 breaths of hypopnea, you have to have a lung-to-ear circulation time that exceeds 27 seconds, you have to have a cycle length. In other words, if you applied other easily measured algorithms to this and identified some of these things that would be easy to identify and reached a high level of precision, then I guess I'd feel more comfortable.
So I guess to kind of summarize what you're saying is not ready for prime time. These methods, the electronic automated detection methods, probably do a fairly good job, but it doesn't replace an expert, a sleep specialist, actually looking at the record and, heaven forbid, actually looking at the patient as well, and making a clinical judgment based on all of the factors that are involved.
Yeah, I actually might even say it this way. If I have a heart failure patient, I don't think the patient care pathway using home studies serves the patient as well as a laboratory study. Number one, I can apply ASV during the laboratory study if they need it. Secondly, I think my precision isn't quite as good for identifying these phenomena as it is for obstructive apnea, where it seems so simple. Mm-hmm. And so and those patients, thirdly, are at greater risk if we do the wrong thing. So I think it has a lot to do with the patient care pathway and some to do with the technology.
Okay, excellent. Well, thank you very much. This has been very instructive. We've been speaking with Dr. Conrad Iber from the University of Minnesota. Thanks very much for doing this, Con. Really appreciate it.
Absolutely. Thank you.